We'll be breaking down major concepts covered on the exam. Because today, we're looking at a scenario that every medical student fears but absolutely has to master.
Yeah, cardiorespiratory arrest and cardiopulmonary resuscitation, or CPR. It's high stakes, to put it mildly.
Extremely high stakes. And before we really get into the weeds today, just a quick reminder for you listening, we are teaching directly from reliable StatPearls articles for this deep dive. But this is for medical education only, not medical advice, and clinical decisions should always involve a qualified healthcare provider.
Right. And the reason we're doing this deep dive is because, well, staring down a cardiorespiratory arrest, it narrows your clinical picture to a tiny focal point. It's a binary state, life or death, time just evaporates.
Yeah, you don't have the luxury of sitting there and pondering the differential, right?
Exactly. And the beauty of this, at least from an exam perspective, is that the American Heart Association and the ILC, or guidelines they're based on, have taken all that chaos and turned it into a highly testable, methodical algorithm.
Which is so reassuring. Like, there's no guessing, just execution.
It's just execution. If you know the steps, you won't fall for the exam traps.
Well, let's look at the first major hurdle in those AHA guidelines, which is literally just knowing when to pull the trigger. Like, when do you actually start the algorithm?
Yeah, the initial assessment.
Because we've all seen that tricky practice question, right? You know, the one where a college student is passed out on a couch at a frat party.
Oh, classic.
Right. Their vitals are severely depressed, and you're staring at the exam screen going, is this severe alcohol poisoning? Is it an opioid overdose? Or is it sudden cardiac arrest?
And the test writers want you to hesitate. They are banking on the fact that you, as a student, do not want to aggressively crush the sternum of a guy who just drank way too much.
Exactly. It feels so aggressive if you're wrong.
But in the field, hesitation is lethal. So the guidelines strip the initial assessment down to just two concurrent clinical findings. Number one, the patient is unresponsive. Number two, they have an absent palpable pulse. That's it. You take no more than 10 seconds max to check the carotid.
Yeah.
If you don't feel a pulse, you assume cardiac arrest. You don't wait to figure out if it was fentanyl or an underlying arrhythmia, because if the pump is stopped, the brain is already dying.
Wow. So 10 seconds and then you are moving.
You are moving.
So let's talk about the underlying physiology of that failing pump for a second. Sudden out-of-hospital cardiac arrest, it claims hundreds of thousands of lives every year. And the most common cause in adults is ventricular fibrillation.
Right, VFib.
So the heart hasn't necessarily just flatlined, right? It's more like it's quivering, like a bag of worms. It's burning through all this cellular ATP, but producing absolutely zero forward blood flow.
Which is a crucial concept, because it means the definitive treatment for ventricular fibrillation is actually not CPR.
Wait, really? It's
Yeah.
not?
No. The definitive treatment is electrical defibrillation. You need an AED to deliver a massive jolt of electricity. You have to simultaneously depolarize all those chaotic cardiac cells and just, well, pray that the heart's natural pacemaker can regain control of the rhythm.
Okay, so if the AED is the actual cure, where does CPR fit into the timeline?
It's a bridge. We're fighting against what we call the 10-minute window. If an AED is not right there, irreversible ischemic brain death is likely going to happen in less than 10 minutes.
Oh, wow. Less than 10 minutes.
Yeah. CPR is a purely mechanical bridge to keep the brain viable until electricity arrives. And it's a bridge with, frankly, a very limited carrying capacity.
What do you mean by that?
Well, even if you do perfect textbook conventional CPR, the chest compressions, the rescue breathing, you're really only providing up to roughly 33% of normal cardiac output.
33%. That's surprisingly low.
It is. You are literally just manually squeezing the heart between the sternum and the spine, trying to force a third of the normal blood volume up the carotid arteries to the brain.
Okay, knowing that we are desperately fighting for just a third of normal output, that actually explains the massive paradigm shift we saw in out-of-hospital management.
The death of the ABCs.
Right. The old ABC method airway breathing compressions, that is completely dead.
Yeah.
The AHA wants us going straight to compressions now. It's strictly CAB.
CAB, compressions, airway, breathing.
And physiologically, if you think about it, that makes perfect sense. Like, flooding the lungs with oxygen is completely useless if there's no pressure head to circulate that oxygenated blood.
Exactly. The pump takes absolute priority. And the exam loves, to test the precise mechanics of how you operate that manual pump.
The numbers.
Yes. For adults, your hands go on the lower half of the sternum. You must compress at a rate of 100 to 120 beats per minute. and you have to hit a depth of at least 2 inches.
Okay, so 100 to 120 beats per minute. I always picture that classic medical school trope of doing compressions to the beat of Staying Alive by the Bee Gees.
Which sounds like a joke, but it's not.
It totally works. It targets that 104 beats per minute sweet spot perfectly.
It's a cliche because it saves lives. But, the real danger in an actual code is adrenaline. Providers naturally speed up.
Oh, for sure. You're panicking.
Right. You start compressing to the tempo of, like, a techno track. You hit 140 or 150 beats per minute, and when you go that fast, you severely cut into the diastolic filling time.
Because the heart doesn't have time to relax.
Exactly. It needs that fraction of a second to passively fill with venous blood between your compressions. If you go too fast, you end up pumping a relatively empty chamber.
Which plays directly into the next major mechanical rule, which is full chest recoil. You have to let the chest wall snap all the way back up on the upstroke.
Yes. Do not lean on the patient.
I visualize it exactly like using an old cast iron manual water pump, like on a farm.
Oh, that's a good analogy.
Yeah, like pushing down on the heavy handle forces the water out. But if you don't let the handle come all the way back up to its starting position...
The chamber underground can't refill.
Right, if you just frantically jitter the handle down at the bottom, nothing comes out of the spout.
And that fluid dynamic analogy is so relevant to coronary perfusion pressure because the heart muscle itself, it doesn't extract oxygen from the blood inside its own chambers.
Right, it has its own supply.
Exactly. It's fed by the coronary arteries, which only fill during the relaxation phase.
Right.
So if you lean on the patient's chest and prevent full recoil, you're maintaining this continuous state of artificial high pressure in the chest. The coronary arteries can't fill.
So you're suffocating the heart while you're trying to save it.
Precisely. No recoil, no coronary perfusion. That is a guaranteed exam question.
Okay, so we're pumping at 100 to 120 beats to a minute, 2 inches deep, full recoil. But, you can't just pump forever.
No.
So the single rescuer out-of-hospital ratio dictates that after 30 compressions, you pause to deliver 2 rescue breaths.
And those 30 compressions are vital because it actually takes the first several pushes just to build up enough aortic pressure to achieve any forward flow.
Oh, so it's cumulative.
Exactly. If you stop at, say, 10 compressions to give a breath, you drop that systemic pressure all the way back down to 0 before you ever even perfuse the brain.
That makes so much sense.
By hitting 30, you maximize the time spent at optimal pressure. Then you give the 2 normal breaths, each lasting about 1 second, just enough to see the chest rise, and immediately get back on the chest.
Okay, but what happens when the AED arrives on the scene? I assume you don't, politely pause your compressions to figure out how to unwrap the electrode pads.
Never. You never voluntarily give up the pump. You or a bystander apply the pads to the bare chest while the compressions are actively continuing.
Okay.
You follow the verbal prompts of the machine. The only time you stop is when the AED specifically tells you to clear the patient to analyze the rhythm or deliver a shock. And the moment that shock is delivered,
you don't stare at the screen to see if it worked.
You instantly slam your hand back onto the chest and resume the CAB sequence. Got it. Now let's look at a subtle exam trap hiding in the airway part of that CAB sequence. Usually, to open the airway for those 2 rescue breaths, you do a standard head tilt chin lift maneuver.
Pulls the tongue off the back of the throat.
Right. But what if the exam stem specifically mentions the patient was pulled from a severe motor vehicle collision? Or maybe they fell off a roof?
Oh, huge trap. In any scenario where a cervical spine injury is even remotely suspected, extending the neck with a head tilt is the wrong answer.
You could literally transect the spinal cord.
Exactly. The correct exam response is always the jaw thrust maneuver.
Right, the jaw thrust.
You place your fingers behind the angles of the lower jaw, and you physically displace the mandible forward without tilting the head back. It secures the airway, but it protects the cervical spine.
Okay, so out of hospital, one-person CPR is pretty straightforward once you know the rules. It's an exercise in endurance and strict adherence to CAB. The 100 to 120 rate, the 2-inch depth, the 30 to 2 ratio.
But the MCCQE loves to change the variables. They really do. They want to see how protocols adapt when the environment changes. So let's move this patient through the hospital doors. What changes in hospital?
Well, the hospital setting introduces multiple healthcare providers and advanced airway equipment. Specifically, the bag valve mask or the BVM device.
Which fundamentally alters the pacing, right?
It does. If we have a team of 2 providers and the patient is not yet intubated, the ratio shifts. We abandon the 30 to 2 ratio.
What does it become?
It transitions to a 15 to 2 ratio. One provider focuses entirely on continuous, high-quality chest compressions. The second provider manages the airway seal with the BVM. After 15 compressions, the first provider pauses, the second provider squeezes the bag twice, and they immediately resume.
So it cycles much faster. I guess that helps reduce compressor fatigue.
Yes, while still delivering essential oxygen.
But the real game changer happens when the anesthesiologist steps in and successfully places an endotracheal tube. Because now the airway is fully secured, and this is where my favorite physiological analogy comes in.
Oh, I know this one. Let's hear it.
Okay, so I think of the flow of CPR, like traffic on a bridge. Non-intubated CPR, whether you're doing 30 to 2 or 15 to 2, is like a narrow one-lane bridge. Compressions and ventilations have to take turns. They can't cross the bridge at the same time because the airway isn't secure.
Right. If you force air in while pushing on the chest, you just push air straight into the stomach.
Exactly. But the moment you slide that endotracheal tube in, you upgrade to a two-lane highway. Compressions can cruise in the left lane, and ventilations can travel in the right lane simultaneously. They never have to stop for each other.
It's an excellent way to visualize the decoupling of the systems. Once intubated, compressions become continuous at that steady 100 to 120 rate. There are absolutely no more pauses.
And what about the breaths?
The provider at the head of the bed delivers ventilations independently via the BVM at a precise rate of 1 breath every 6 seconds.
So that's exactly 10 breaths per minute.
Yes, 10 per minute.
And this leads us to one of the most fatal clinical errors. It's a highly favored exam trap to hyperventilation.
Oh, this happens all the time in real codes.
Yeah. The adrenaline is pumping. The provider holding the BVM feels like they aren't doing enough, so they just start squeezing that bag rapidly. Instead of 1 breath every 6 seconds, they're delivering a breath every 2 seconds. Physiologically, why does that doom the patient?
It comes down to the physics of intrathoracic pressure. When you manually squeeze a BVM, you are forcing positive pressure air into the lungs. If you do this too rapidly, you essentially turn the chest cavity into a high-pressure balloon.
Oh, I see.
And that massive pressure surrounding the heart physically compresses the superior and inferior vena cava. Blood from the body literally cannot flow against that high-pressure gradient to return to the right atrium.
Wow. So venous return plummets.
Plummets. And if there is no blood returning, there's no blood for the heart to pump. Your beautiful, perfect, continuous chest compressions become totally useless because you are squeezing an empty heart.
That is such a clear mechanical consequence. Overventilating literally chokes off the blood supply to the heart. So strictly 10 breaths per minute once intubated.
Got it.
Yeah.
Let's pivot to another area where the mechanics shift, which is pediatric patients.
The exam requires you to know the strict age definitions here because they dictate your physical approach. Infant CPR applies from birth to 1 year of age.
Okay, birth to 1.
Child CPR covers patients from 1 year old up to the onset of puberty. And anyone post-puberty falls under the adult guidelines we just discussed.
So the core principles remain identical, right? It's still CAB. You still target 100 to 120 compressions. Single rescue out of hospital is still 30 to 2.
Yes. What changes dramatically is the depth and the physical technique used to achieve it. For a child between 1 year and puberty, their chest wall is smaller. It's more cartilaginous. The target depth is approximately 1/3 of the anteroposterior diameter of the chest.
1/3 the AP diameter, which roughly translates to the adult standard of 2 inches, right? Roughly, yes. However, depending on the physical size of the child, you might only need the heel of 1 hand instead of 2 hands to safely achieve that depth.
And for an infant under 1 year old?
The absolute depth changes, but the proportional depth remains the same. You're still aiming to compress the chest by 1/3 of its AP diameter. But in an infant, that is approximately 1.5 inches.
1.5 inches. And you certainly aren't using the heel of your hand for a baby.
No, absolutely not. You use 2 fingers placed directly on the sternum, just below the nipple line.
Okay, so those precise figures, 2 inches for adults and children, 1.5 inches for infants, always aiming for 1/3 the AP diameter, those are highly testable metrics that you just simply have to commit to memory.
Absolutely.
So we've mapped out the mechanics beautifully. We know how to pump, how fast, how deep. We know how to avoid the deadly traps of hyperventilation and loss of recoil. Let's talk about the aftermath. Say we execute the algorithm perfectly. What are the actual clinical odds for the patient?
Well, the reality of out-of-hospital cardiac arrest is grim. I mean, according to the AHA data, survival to hospital discharge for these patients hovers between 10.6 and 10.8%.
Wow, just around 10%.
Yeah. And among that small fraction of survivors, only 8.3% will leave the hospital with good, intact neurologic function. The ischemic damage just happens incredibly fast.
But, the data also provides a massive incentive for early intervention because if the arrest is witnessed or if it happens inside the hospital where high-quality CPR and defibrillation are initiated immediately, that survival to discharge rate jumps up to 25.5%,
That's right. High-quality compressions more than double the odds of survival.
which is huge.
It is. But even with survival, the post-resuscitation hospital course is incredibly complex. The patient has endured profound systemic shock.
Right.
You have to anticipate and manage hypoxic encephalopathy from the brain being starved of oxygen. There's widespread ischemic injury to the kidneys and liver, and frankly, there's the direct physical trauma inflicted by the resuscitation itself.
And that physical trauma, that actually brings up a major mental hurdle for medical students. The guidelines explicitly state that correctly performed chest compressions frequently cause rib fractures, which, can further complicate into a pneumothorax.
They do.
I remember the first time I realized you have to push hard enough to potentially break a human being's bones.
Oh.
It feels like a direct violation of the do no harm oath. Like, it feels like assault.
It is a profound psychological barrier. Many inexperienced providers subconsciously hold back on their compression depth because they hear a crack and they're terrified of causing injury.
Yeah, that cracking sound is awful.
But you have to ground yourself in the brutal pathophysiology we discussed. Without that 2-inch depth, there is zero perfusion to the brain. A fractured rib or a punctured lung, that is a complication of life. They can be treated.
Right.
Inadequate compression depth is an absolute guarantee of death.
A fractured rib is a complication of life. That completely changes the perspective.
Yeah.
So the exam also expects us to understand the administrative and protocol boundaries of resuscitation, right? If an arrest happens in a clinical setting, we aren't just blindly compressing every chest we see.
Right. You must immediately ascertain the patient's code status. If a patient has a legally valid, documented do not resuscitate order, or an equivalent advance directive that aligns with local laws, it must be honored.
It's not optional.
It's not a philosophical debate. It's a strict algorithm branch point. Ascertaining code status and notifying the patient's surrogate decision-maker is just as critical to the physician's role as knowing the compression ratios.
It's the ultimate reminder that we're treating human beings with documented wishes, not just biological machines.
Exactly.
All right, let's do a rapid-fire synthesis of the essential mechanisms we covered today so you listening have this locked in for the MCCQE.
Let's do it. The fundamental sequence is CE compressions, airway, breathing. You prioritize the pump over stationary oxygen.
The compression rate is globally 100 to 120 beats per minute. Faster is not better. You must allow for diastolic filling.
Depth is at least 2 inches for adults and children and 1.5 inches for infants. And full chest recoil is absolutely mandatory to maintain coronary perfusion pressure.
For out-of-hospital single rescuers, the ratio is 30 compressions to 2 breaths to maximize pressure in the aorta.
In hospital, with 2 providers and a non-intubated patient, the ratio shifts to 15 to 2.
Once that endotracheal tube is in, it becomes a 2-lane highway. Compressions are continuous. Breaths are delivered completely independently at a rate of 1 breath every 6 seconds or 10 per minute. Do not overventilate and crush the venous return.
And finally, if there is any suspicion of cervical spine trauma, abandon the head tilt and use the jaw thrust maneuver to secure the airway.
If you can internalize not just the numbers, but the underlying fluid dynamics and physiology behind them, you will easily navigate the cardiovascular section of the exam. The AHA algorithm is literally engineered to take the panic out of the room. Just trust the physiology and trust the training.
You know, as you close the books for the day, I want to leave you with one final thought to ponder. Consider the strange paradox of cardiopulmonary resuscitation.
What do you mean?
Well, we dedicate countless hours of medical education, physical training, and simulation to perfecting the depth, rate, and recoil of chest compressions. We analyze the exact fractions of cardiac output we can generate. Yet, the definitive treatment for the most common cause of adult sudden cardiac arrest remains electrical defibrillation.
Right, the AED.
It forces you to internalize a humbling reality. As a physician in a code, despite all your knowledge, your hands are simply acting as a temporary mechanical battery for the brain. You are entirely dependent on how fast you can get electricity to the scene.
Wow. Just a mechanical bridge, trying to keep the lights on until the real power arrives. That is a heavy but powerful thought. Keep studying, keep pushing the boundaries of your clinical understanding, and we will catch you on the next deep dive.